Ma'am, 61 participants are there.
Okay. Acha, are you able to hear me clear enough? Because actually we are in
Yes,
college and
ma'am.
there's work going on, so I'm not sure whether you can hear me properly.
Yes, ma'am, you're audible and it's clear.
Oh, oh, okay. So we start. Let people join in. Okay. The topic is abscess ulcers. Okay. Last time I think lichen planus was taken, right?
Yes, ma'am.
Oh,
Yes, ma'am.
so we take abscess today. We all have seen ulcers, and most of us must have experienced some ulcers at some point of the time. Okay, so abscess is very common, and it has been since ages a topic of so much research. Why? Because even after knowing a lot about this, we still don't know something main about this, because of which we don't know exactly what management this condition requires. Okay, so we try all symptomatic treatment and some other things which were proposed as the ecological factors, but none has been proven very effective. Fine. So abscess ulcers, also known as canker sores, it was given as a first term in Hippocrates. That means by Hippocrates. So imagine, since so many centuries we know this condition, but yet we have not been really able to find out what proper drug of choice would really work on this abscess ulcer. This is characterized by recurring ulcers confined to the oral mucosa in patients with no other signs of disease. It is considered a diagnosis of exclusion. So by this what we mean is, whenever we cannot diagnose anything else, then we diagnose an ulcer to be of abscess ulcer. Because if we know there is trauma as the cause, then it's a traumatic ulcer. If we know the patient has viral fever and then he had an ulcer, we call it viral ulcer, like herpes or herpangina. Okay. If we know the patient has given history of chemotherapy, radiation therapy, and after that he is having ulcers, so we know these are ulcers because of chemotherapeutic drugs. But when we can relate nothing else to the cause, then the diagnosis by exclusion of all other conditions, then your diagnosis becomes abscess ulcer. Okay, so there is no specific etiology, but still if the patient keeps on having ulcers, it is abscess ulcer, and they are recurring. This affects 20% of the general population and
Ma'am,
specific. Yes.
sorry, ma'am, there are people in meeting.
Okay. Okay. Wait. Okay. Yeah. So this affects 20% of the general population and specific ethnic or socioeconomic groups are studied, and the incidence ranges from 5 to 50%. That means there are some ethnic groups, depending upon their genetic makeup or maybe some other factor, they are more prone. Right? So this is how abscess ulcer is prevalent in the population. Now, so many things have suggested to be the cause. That means we can relate some of these as the etiological agent with abscess, though none of them are the only etiological agent, maybe a combination or just something which is related to this, but we don't know exactly which one. Like genetic and immune dysregulation. That means there is some problem with the genetic makeup of the patient, or there is some problem with the no one knows. There is something wrong with the genetic makeup which is, present from generation to generation. So there is a problem with abscess in a family, that is okay. But exactly what is wrong is not known. Then there is a second etiological agent suggested in microbial aspect. That means there could be some microbial infection which is causing abscess. Third is local factors. Local factors like any trauma or the patient has suddenly stopped smoking, or there is some hypersensitivity to some food. All this could be one of the factors, and systemic factors like small deficiency. Maybe the hematologic deficiency, nutrition deficiency, or some other systemic disorders. So all this are suggested as some of the etiological agents. So either one is present or none of them are present, or even if one is present exactly, that could not be the cause in that patient, or maybe if he has 3-4 times episodes of abscess ulcer, every time there was some other cause. So any of this can happen. That's why, because of the obscure nature of the etiology, the management is also not very centered. Right? So this is some of the etiological factors for abscess. In case if there is someone waiting, please let me know when there are a handful of people, so I can shift the screen again. Okay. There are some syndromes which are associated with abscess. Many are there. For you, at least for your portion point of view, you should know names of most and the details of one or two. Okay. So in detail, you should know the Behcet syndrome. Behcet, you all must have heard the name Behcet syndrome. It consists of recurring oral ulcers, genital ulcers, and eye lesions. Okay. So it is a triad of oral ulcers, genital lesions, and eye lesions. Along with this, there are some skin lesions also, and there is a positive pathology test. This always is asked in an MCQ. That pathology test is positive in which condition? Okay, so it is Behcet syndrome. So always remember, it's a triad of oral lesions, genital lesions, and ocular lesions. The next is Magic syndrome, Sweet syndrome. Only remember the names of these two. You need not remember what is inside. So there's something like Magic and Sweet syndrome, which is also characterized by abscess ulcers, and PFA-PA syndrome, that is periodic fever, Aphthae, pharyngitis, and adenitis. Okay, so this is also a syndrome which is associated with abscess ulcers. So majorly 4 are there: Behcet, Magic, Sweets, and PFA-PA syndrome. Then there is a condition known as cyclic neutropenia. This is a hematological disorder. In this, what happens is every 21 days, there is cyclic reduction in the neutrophils. That means at the end of 21 days, you will have almost no neutrophils. There are very less of them present, if not no. And then after the phase, again, it will start rising. So the patient is alright for the 21 days, but when the cycle of neutrophils falling down starts, neutrophils are mainly responsible for fighting against infections. Okay, so when that is not there, you will be more prone to infections, you will be more prone to whatever things will happen in case if there are infections residing inside the body. Okay, so what it shows is as symptoms: fever, oral ulceration, some cutaneous abscesses, upper respiratory tract infections, lymphadenopathy, severe gingivitis, and aggressive periodontitis. Okay, so this is seen in cyclic neutropenia, and abscess is also one of those features. HIV, yes, HIV disease, because of immunodeficiency, even abscess are seen in HIV disease. So what we have seen until now is the possible, yes, people waiting.
Yes, ma'am.
Yes. Okay, so what we have seen till now is what are the possible etiological agents for abscess, and in which conditions other than those etiological agents we find these abscess, like those syndrome in cyclic neutropenia and in HIV conditions, right? Now we will see the types of ulcer. We all know there are 4 major types of ulcers. You have been studying them, you have been studying them in OPAT, and you have heard of all these 4 major types. There is abscess minor, abscess major, herpetiform, and severe minor ulcer. Right? So these are the 4 types. Let's see each one of them. Now, when you have the episode of abscess ulcer, so what do we see is the first episode generally happens somewhere around the second decade of life, and before the ulcer comes up, the patient will show signs of some burning sensation, some slight erythema, that means inflammation in the area where the abscess is going to come. Then a white papule will emerge, and that will enlarge and ulcerate. Now, most of the time, what will happen is most of the patient will not realize these 4 prodromal symptoms, because generally he will not be paying attention to some slight burning which is there or some papule which is there, but only when the ulcer turns up and it becomes painful, because abscess ulcers are very painful, then he will realize, okay, there is something like an ulcer coming up, okay. And how are the ulcers? They are round, symmetric, shallow, but there are no tissue tags, okay, and there are multiple lesions may be present or single may be present, but the most common area where they are present are the buccal and the labial mucosa, and they are less on the keratinized mucosa, okay. So this is very important feature of abscess, that they will never occur on keratinized mucosa but always on the mobile mucosa, which is labial and buccal. So this will help us to differentiate the other conditions from abscess. Now if we compare major, minor and herpetiform, this is what they show. Incidence, most common is minor abscess, while major herpetiform are less common. Areas affected, most of them will be on non-keratinized mucosa, okay, none of them will be on keratinized mucosa. Size, less than 10 mm is for the minor abscess and more than 10 mm is for major, because they are major, they are bigger in size, and herpetiform are very small in size, but the number is very large. That means the minor abscess are hardly 1 to 5 in number, major would be 1 to 10, but when you have herpetiform ulcers, you have those pinpoint 1 to mm ulcers, but they are in crops, like even 150 can be there. Healing of the minor ulcer occurs in 10 to 14 days. Major abscess, they heal but they scar, and herpetiform they also heal in 10 to 14 days, okay. So moreover, healing occurs on their own, and most of the abscess will not leave any scars, but the major abscess, when they heal, they will heal with scarring. So this is a typical presentation of minor abscess. Okay, you can see two. Can you see the almost circular shape, well defined, and can you see the erythema around it? Okay, so that is a classical sign that there is inflammation around the ulcer. This is major. Major, the size is very big. Can you see a big major ulcer which is present? There are two in fact. Okay, and they are posterior to the last molar, but on the mucosa which is non-keratinized. Okay, the partial pillars and the mucosa over here, it is non-keratinized as against your attached mucosa. Okay, so they are occurring over here and the size is very big. This is abscess major. Herpetiform. Then you see small circular ulcers are present at the side of the tongue, right from the tip to the most posterior aspect. Okay, how much the tongue has been shown, almost till the posterior aspect, you can see all these small formations. So these are herpetiform ulcers. Okay, so these are small ulcers, but too many. Minor are small, but there are hardly 1 to 2, and major are less in number, but they are very huge. Okay, so diagnosis, we have already seen that you have to exclude other diseases to diagnose abscess. History is what you need to ask is in case if there are any blood dyscrasias, any systemic complaints or ulcers which are present any other than the oral cavity, like skin, eye or genital lesions are present. And biopsy, when you suspect any other granulomatous disease, then you have, or any connective tissue disorder, like you suspect there is some major systemic problem, only then go for biopsy to see whether anything specific is present or it is just non-conspicuous inflammatory ulcer like the abscess ulcer. And you can also ask the patient to have their iron, folate, vitamin B12 checked by, because we know nutritional deficiencies is one of the major cause of abscess ulcer, so even this can be ruled out. And any allergy or gluten sensitivity, which has also caused maybe the eruption of ulcer. So this can be used as investigation purpose. And in case if nothing of this is very specific for the patient, then clinically how will you segregate or how will you differentiate between an abscess ulcer and a traumatic ulcer? Okay, because abscess can be most commonly confused with traumatic ulcer or ulcers of viral origin, or we will see one or two conditions where then you need to differentiate those ulcers from abscess ulcer. Okay, so abscess is, the shape is round oval. Traumatic ulcer, because it is trauma, so you don't know exactly how it was, so the shape is irregular. Abscess single or multiple, traumatic ulcer will be single, yes, because it's just a traumatic ulcer, okay, because of trauma. So only that specific area has been traumatized, so we'll have ulcer over there. the abscess ulcer, they heal and reoccur in other locations because they are always recurring. Okay, but traumatic ulcer will heal. And in case only when there is new trauma can this ulcer come up. Otherwise, it will not come. Okay. And erythematous halo, very, very important. If you have, remember the picture which we saw just now about the abscess, the erythema is there around the ulcer. Okay, so that is a classical sign. Here in traumatic ulcer, it is ill-defined. And this occurs on non-keratinized mucosa, and traumatic ulcer can obviously occur anywhere because wherever there is trauma, you can expect an ulcer. Okay. So, can you see this? The lesion on the tongue, the ground picture is of traumatic ulcer. This is typical ulcer because of trauma, maybe tongue biting or something like this. Okay. And what you see up is abscess ulcer. So, if you can see the inflammation around the ulcer in the top picture, you can see the erythema which is present. And down, you can compare both the ulcers and see, you can clearly differentiate which is a traumatic ulcer and which is an abscess ulcer. Recurrent abscess ulcer and herpes simplex. Okay. So now these are two more conditions where we have to differentiate the ulcers in herpes and between abscess. Abscess, this can occur in any age, more than younger, that means after the second decade of life. And herpes, the recurrent herpes will always occur later in life. Okay, because that's the secondary infection of the primary herpes. So this will occur more in older age, but abscess is younger age. Non-keratinized mucosa, yes, we know that, and intraoral herpes will always occur on keratinized mucosa. Vesicle formation is not there in abscess, in herpes it is vesicle formation. I don't know if herpes is taken, but herpes always is preceded by vesicle formation and the vesicle ruptures, and then you have ulcer, but this is not seen in abscess. Then abscess, recurrent abscess ulcer is usually single, multiple, 1 to 5. And herpes are the multiple ulcers and they join together form bigger ulcers. Okay, so that is one more characteristic. And when you stain abscess ulcer tissue, that means on biopsy, it's a non-specific histopathology. While on a section of herpes ulcer, will show you typical characteristics of Bononian degeneration, giant cells are seen, virus infusion bodies are seen. You must have heard these terms in OPAT. Okay, so this is how you see them on cross section, that means your HP section. Scarring for major abscess, intraoral herpes is always healed without scarring. For abscess, they heal by itself. Steroids can be given in case if there is a lot of pain, but because herpes is a viral condition, you cannot give steroids. Steroids are completely contraindicated. Fine. Now, can you see, compare the top picture is of minor abscess and the lower one is of herpes. Okay, so herpes are multiple, okay, but they are going to grow in size and become a big ulcer. While typically of your abscess, the size is round, the size is small, shape is round, and you can see the halo or the erythematous halo, that means the inflammation around it. Okay, so this is abscess and herpes. Now abscess and vessels. We have seen even vessels will show abscess, but vessels will show lesions elsewhere also, that means in the ocular area and the genital area, while abscess is just, the normal usual abscess will only occur in the oral cavity. Okay, yeah. So this is like the down picture is of vessel syndrome. They are ulcers in vessels are supposed to be more deeper as compared to the abscess ulcer. So even this can be used as one more distinguishing characteristic. Now, abscess ulcer and squamous cell carcinoma. Now, we all know whenever we see a non-healing ulcer, we always call it, this would be a malignancy because the ulcer has to heal. If ulcer is not healing, that means the cause is the malignant problem. Right? So, how will you differentiate a single non-healing ulcer from an abscess ulcer? Abscess can occur generally from the second decade of life to till the patient is alive. Okay, so any time you can have abscess ulcer. But squamous cell carcinoma is generally in the older group. Yes, the abscess ulcers are very painful. And the squamous cell carcinoma, that means any malignant ulcer, it will be there. It will be non-healing, but pain will not be substantial. While even a very small pinpoint ulcer of abscess will be painful, but even a squamous cell carcinoma, which is of a bigger size, but still the patient won't complain of a lot of pain. So this is one of the major differentiating factors. Lymph nodes may or may not be enlarged in abscess. Squamous cell carcinoma, most of the cases they are enlarged, but the painless and metastasis could be present, not be present. Okay, so that depends upon the stage of the squamous cell carcinoma. This is abscess is surrounded by erythematous halo. We have seen that here the tissue is indurated. That means because it is burrowing inside, you will have induration of the tissue. And healing is, within 1 to 2 weeks. And squamous cell carcinoma is a non-healing also. So you can even differentiate by keeping a wait and watch strategy. The squamous cell carcinoma is not going to heal. The abscess ulcer will heal on itself. Okay, so can you see in the lower picture on the lingual mucosa near the lower 7 and 8, there is a non-healing ulcer. This is squamous cell carcinoma. So it's a big ulcer and it is not typical how an abscess looks like. This is how you can differentiate. And the last comparison is between abscess and pemphigus. You must have heard of pemphigus, okay? So it is a mucocutaneous disorder. That means it can happen in the oral cavity as well as on the skin. Okay? Pemphigus vulgaris. The major differentiating factor is vesicle formation. Again, in pemphigus you will have vesicle, they rupture and then the ulcer is formed. While in abscess there are no vesicles which are there. The pemphigus is a chronic condition. That means the ulcer is not going to turn up within a day or two. But abscess, it will be like yesterday the patient had nothing, but today an ulcer has come up. Okay, so it can be that fast. No tissue tags are present. In pemphigus, there are tissue tags which are present. When we see pemphigus in detail, you will know what is called a tissue tag. Nikolsky sign. Have you heard of this? Nikolsky sign. Okay, so this is a characteristic of pemphigus. That means when you just happen to touch even a normal area, you will have that bulle forming in pemphigus. That is Nikolsky sign. Okay, that is positive in pemphigus, but not present with the abscess ulcer. So now, if you can see the bigger lesions, the tongue lesions are of normal abscess ulcer, and if you can see the pictures on the right side, the whole buccal mucosa is involved and very erythematous because there are big vesicles or bullae and they rupture and they form large ulcers. So those are ulcers of pemphigus. On the left side down, it's an abscess ulcer. You can see the halo, but right side below picture of the labial of the lingual of the lip, lower lip is a bullous pemphigus vulgaris. Okay, because the bulla is there which has busted, and you can see the bleeding also happening in this area. So this is difference between vulgaris lesion and abscess ulcer. So now what do? We have seen ulcers of so many conditions. We know there is possibility of so many etiological agents with abscess also. Even if we don't know that etiology, we have to provide management because the patient is in pain. Pain is a major characteristic. Okay, so what we have to do is first we have to relieve the discomfort, reduce any secondary infection which could occur in this area. You have to promote the healing of the ulcer, and you have to lessen the recurrence of new ulcers. So these are your 4 aims. So what we do is, one, certain food should be avoided. You have to ask the patient, okay, don't eat too much acidic or very salty or very spicy, which would trigger the ulcer and also cause more pain. Okay, and dental products containing sodium lauryl sulfate, none of those which come now have sodium lauryl sulfate. It was a very very ubiquitously used ingredient earlier, but now it is not present. So this shouldn't be a problem. But one is you have to ask the patient to avoid any acidic, salty, or spicy food. Then what we can give is we have to give something which will soothe the pain or cause less of sensations to the patient. So topical anesthetic or topical analgesic like 2% lidocaine or diclofenac benzanidine HCl, which is 0.15%. So either of this can be used as topical application to relieve the burning sensation and the pain of the patient. An antiseptic mouthwash like Chlorhexidine, which has antibacterial properties, and also healing of the tissue can happen with this. Antibiotics are given when you suspect there could be any microbial cause, like some other infection is there or even fever has come up. So then antibiotics can be given. and steroids, very useful, and they have become the first line of treatment in abscess. Why? Because pain is a major characteristic, and steroids are known to reduce inflammation. So if your inflammation goes down, the pain is going to go down. Right? So topical corticosteroids are become the main drug of choice for abscess ulcers. So what can we give? We can give clobetasol, propionate 0.05%. We can give hydrocortisone, hemifluoxamide, triamcinolone acetonide. This is very commonly used. Tetrametazone, and the brand names are Test, Buckle Paste, Kenaport. Okay, so these two are more commonly used, and they are given as form of topical application. Either the patient can put on the finger and apply, or he can take on a cotton swab and then apply over the lesion. Fine, the larger lesions can be treated by placing a gauze sponge containing the steroid, and then you keep it near the ulcer for 15-20 minutes. Intralesional steroids can also be given, because when you have very large ulcers, you can directly